Sorry?
We can start, madam.
Okay, fine. So good evening, students. And as I have discussed today, we'll start with a series of classes on labor, and the first class being always on the normal labor. Okay. So as we begin the class, one thing what you have to understand is the physiology of labor. First of all, the definition. It's the series of events that take place in the genital organs in an effort to expel the viable products of conception. So it's the fetus, the placenta, as well as the membranes out of the womb through the vagina into the outer world is called as labor. Right, and a patient who is in labor is called as a parturient, and it is also called the parturition. Sometimes the whole process is called parturition, and the patient who is in labor is called a parturient in labor, and its parturition is a process of giving birth. So this is about the definition and what exactly you mean by labor. Now, how did this word labor was coined or it came into existence is that, you know, a labor or delivery of a baby involves a lot of expenditure of energy. It's like a very heavy work which the laborers do, you know, in case of lifting heavy weights, in case of building or in machinery, etc. So as much energy as it is involved in such work is what is involved during the labor process, and the mother has to use her full energy and full force to, you know, actually deliver the baby safely or into the outer world. So that's how the term labor came into existence, simulating it to a very high energy required job or a work where the mother has to really spend a lot of energy and, you know, really work hard to deliver the baby. So that's how the common term of labor was coined, but otherwise the medical term is a parturition, and the patient is called a parturient, right? Next one. So normal labor, whenever there is a process of labor occurring, the medical term for it is eutortia. That means the normal process of labor, whereas the opposite is dystortia. So anything abnormal in the labor, be it starting from the onset of the labor pains, or, you know, abnormalities in the position of the baby, abnormalities in the descent of the baby, or even abnormalities like bleeding or placental abruption, or even in the third stage like placental non-separation of the placenta. So anything which is deviating away from a normal process of labor is called dystortia generally, and the normal process is the eutortia. So the labor is called normal if it has to fulfill the following criteria. So when do you call it as a normal labor? And many a times the patient comes to you telling that, you know, they want a normal delivery. So that's how is the term for a normal labor, or the criteria which have been formed. So what are these criteria? There are 6 important criteria. You should always remember these. So when do you call the labor as a normal? The spontaneous in onset. That means it's naturally started on its own. It's not where you induce it with artificial you know, methods, like where you use a prostaglandin or even a syntocinon drip, or sometimes you use induction gels and all that. So that kind is artificial labor, whereas when it occurs spontaneously on its own is what is the first criteria. Second criteria is that it should be at term. So term, you all know that it is defined after 37 completed weeks of gestation is the term, is the time when we call that the pregnancy has attained the term, and the normal labor should have an onset after the term or after the completion of the 37 completed weeks of gestation. So before that, if at all the labor sets in before the completion of the term or before the 37 completed weeks, what do we call it as? Anybody? It's a simple thing. I just want you all to be active with me. That's all. What is labor which is with the onset of more than 37 weeks called as?
More than 37 it is term. Before that it is preterm.
Preterm, yes. So it's a simple thing, and you just remember that it's preterm labor and labor. So normal labor is, it has to occur after term. What is the third point which has to be in line is that the baby should be in vertex presentation. Okay, so remember, cephalic presentation is not a normal position for labor. So in the cephalic presentation, the baby has to be specifically in a vertex presentation. That means that any other presentation of the fetus, even though it is in cephalic presentation, for example, face presentation or a brow presentation, are not considered to be normal presentations for a normal labor. So only if it is a vertex presentation is what when we consider it as a normal labor. Okay. Then the fourth criteria is without undue prolongation. See, always remember that the labor will have certain stages, the first, second and third stage of labor. So each and every stage of labor has an average duration or a normal specific time for its completion. So any of the stages of the labor should not have any prolongation or abnormalities to be considered it as a normal labor. So each and every stage of the labor has to go through a proper duration to say that it is a normal labor. So without undue prolongation of any of the stages of the labor is what we call it as a normal labor. Then the fifth term criteria is that natural termination of the minimal aids. That means we do not use any special assisting instruments. For example, the forceps or the vacuum are not used in normal labor. So when we use it, we don't call it as a normal labor. So the delivery should be a natural one, and with the minimal aids suggests that it could be a small episiotomy, or it could be a support, or the perineal support, or the mild fundal push, or what you give is what is called as a minimal aids. Apart from these, if you use instruments like, as I told, forceps, vacuum, it is considered as a assisted or operative vaginal delivery, not a normal labor. Then the last one, that is without having any complications affecting the health of the mother or the baby. This is very, very important at the end of the labor, especially after the fourth stage of the labor. Is what we look for is that both the mother and the baby should be stable, in a stable condition, and she should not be having any complications like PPH or hypotension or shock or any other issues. And of course the baby should be normal as well. So considering these things, you all should now understand that defining that the labor was a normal delivery or an eutosia is actually a retrospective diagnosis or terminology what we use after it has fulfilled all these criteria after the fourth stage of the labor. So this is how the definition or criteria for normal labor is, and as you understand, it's a retrospective diagnosis. So anything as I told above and away from it will be an abnormal labor, which we call it as dystocia. Fine. I hope you all have understood this clearly.
Yes, ma'am.
Yeah, so we'll proceed to the next one. Now, pre-labor. Pre-labor is a stage before the onset of the actual labor. There are certain changes which are occurring in the mother, and they can be noticed by herself as well as the obstetrician. So those are the changes what we observe for about 2 to 3 weeks before the actual onset of the true labor. Okay, especially in primary gravida, they occur quite early, and in multipara, they might occur just 1 week early or even 1 or 2 days earlier only. Whereas in primary gravida, they occur almost 2 to 3 weeks before the onset of the labor. And so many times the primies come, to the OPD saying that they are very apprehensive. They do not understand, first of all, and if there is any deviation from the normal thing like mild contractions or backache or discharge, they come over to you again and again, but they are not in labor. So this happens about 2 to 3 weeks before the actual onset of the labor. So what that period we call it as a pre-labor. It is associated with an increase in the oxytocin receptors in the myometrium. It's like a preparation for the actual labor, and therefore there are a lot of changes occurring in that time. One is that the oxytocin receptors in the myometrium increase. The changes seen during pre-labor are lightening. So that is the terminology which kind of is a feeling by the mother, and there is sudden decrease in the fundal height is seen at term. Now this is due to the formation of the lower uterine segment, and this allows the presenting part to descend into the pelvis suddenly. So it brings a sense of relief to the mother. So the mother will be having a lot of pressure, especially in the upper abdomen and the gastric stomach and all that, and even the there is a kind of difficulty in breathing because of the pressure on the chest as well. So when there is a sudden descent of the presenting part because of a formation of the lower uterine segment, so it kind of relieves the mother of that pressure, and it kind of she feels that there is a light sensation in her body. So that is why it is called as a lightening, and it is one of the signs of pre-labor. Then is the cervical ripening, where the cervix starts softening, and she can feel this in the terms of a mild backache or even mild discharge. So this is cervical ripening. And then false labor pains. So a lot of times, especially the primees, come with false labor pains, where they feel that they're in labor, they feel the pain, the backache, and then they come to you, several times, but they are actually not in labor. So that is what is important for you to identify whether the patient is having a true labor pain or a false labor pain. So how do you identify whether the patient is in true or false labor pain? Is now by this chart, you should remember certain points which will help you identify it. So what are these changes you have to note is, like, one is the cervical changes in terms of dilatation and effacement, then frequency and duration of the contractions, pain experienced by the patient, the bag of the water or the membranes. Show is nothing but it is a mixed discharge that is mixed with the cervical mucus, the blood, and some sort of tissues which are expelled because of the dilatation of the cervix. It will be like a plug sitting at the internal os and the external os. Okay, it will be like a covering the cervix or the cervical canal. But once there is some amount of cervical ripening as well as effacement, that particular the discharge is suddenly, it comes out because of the dilatation, and because of the minimal dilatation of the cervix, there will be small blood vessels there which will get torn off, and that will lead to a bit of bleeding. So therefore it will be a blood stained mucoid kind of a discharge, and sometimes it will be very thick, and it will be like a plug of mucoid. So that's what is called as show. Then there, how it relieves the pain, how the pain relieves with the enema or sedation is another criteria to diagnose whether the patient is having a true labor pain or a false labor pain. So when we take up these points, what happens when a patient having a true labor pain is that the cervical changes, that is dilatation and effacement, will be present. Right. So this is one of the very important criteria to say also that the patient is in labor. So you always check whenever the patient is coming to you with pains. Of course, after doing the general examination, after examining the uterus for the contractions, you have to do a pelvic examination and see if there are the changes, expected changes in the cervix, that is dilatation and the effacement, is present or not. So it is present in if it is true labor pains, and it is absent in false labor pains. Next is the frequency and duration of contractions. Here in true labor pains, the contractions are regular and they gradually increase in terms of frequency, intensity, as well as duration. So all the three parameters in case of a contraction are supposed to be increasing over a period of time if the patient is in true labor, right? As I told, it has to increase in frequency, it has to increase in the duration, the contraction lasting for, that is the period is called as a duration, as well as the intensity. So these three parameters are important to be observed in the contractions, and they have to increase in true labor pains, whereas they're very irregular or not at all present in case of false labor pains. Now, the pain experienced by the patient will be mostly in the lower abdomen and back and radiating to the thighs typically, whereas it is only in the lower abdomen, and there is no typical radiating factors present in the false labor pains. Now, the bag of water is what we do or examine on pelvic examination, is since there is a dilatation of the cervix, there will be funneling or herniation of the membranes. So if it is well formed bag and you can feel the membranes, it shows that she's already in labor, there is cervical dilatation and effacement, and that is what you can feel, the well formed bag of membranes in true labor pains. Whereas it is not formed, or you may not even feel it because the cervix is not dilated here in false labor pains, you cannot even feel it. So, and therefore it is not formed. Next, is show, as I discussed earlier, it is present in true labor pains, it is absent in false labor pains. And the pains in case of true labor pains, after you give an enema or a sedation, do not subside. They do not vanish away, or they do not subside. In fact, as I told, they should increase in frequency, intensity, and duration. Whereas if they are false labor pains, usually because of, if they are caused by gastric upset like constipation or indigestion or anything like that, they usually get relieved by giving an enema. So that's how the difference you have to appreciate whether the patient is having a true labor pains or a false labor pains. Is it clear to all of you? Yes, students?
Yes, ma'am.
Fine. So we'll go to the next slide. So true labor pains is the onset of true labor pain is characterized by appearance of the labor pains, as we discussed, appearance of show, and each labor or the parturition is divided into 4 functional stages. So this is very important to understand the stages of the labor, and I want you all to understand this, and without any doubts, right? So this labor is divided into 4 stages: the first stage, second stage, third stage, and the fourth stage. The first stage is the stage which we differentiate, or which we categorize, is when it starts with the onset of the true labor pains and ends with the full dilatation of the cervix, which is normally 10 centimeters in a term gestation. The full dilatation of the cervix is equal to almost 10 centimeter dilatation. So this is the first stage of labor. And the average duration of the first stage of labor is 12 hours in primi and 6 hours in multipara. The second stage of the labor, it starts with the full dilatation of the cervix and ends with the expulsion of the fetus from the birth canal. So the normal duration is, it's almost 0 to 2 hours in primi and 30 minutes in multipara. So I cannot say 0 in actually primi. It is actually 1 minute, at least 30 minutes to 2 hours in primis, and 0 to 30 minutes in multipara. That means it could be a sudden expulsion of the baby within few seconds of full dilatation of the cervix sometimes, and it occurs in conditions like precipitate labor, and in fact we don't consider it as a normal duration of the second stage. So it has to be at least 15 to 30 minutes is what average in multipara, and about 30 minutes to 2 hours in the primary gravida is considered as the normal duration of second stage of labor. Then comes the third stage of labor. After the delivery of the baby or the fetus, the expulsion of the placenta and the membranes, or what you call as afterbirth. This is called as the third stage of labor. The duration is about 15 minutes in both primi and multipara, and the duration is, however, reduced to 5 minutes if you have conducted an active management of the third stage of labor. So we'll understand what you mean by active management of third stage of labor in the subsequent slides. So without any intervention, the normal duration of third stage, that is the delivery of the placenta and the membranes, is about 15 minutes is what you have to remember. Then comes the fourth stage, and this is a very critical stage and a very important stage, especially for the maternal well-being, and it is very important that you do not miss the fourth stage of the labor, and always see that the patient is well monitored and observed in the fourth stage. So it's about an hour after the delivery is what we call it as the fourth stage, and that is after the delivery of the placenta. Physiological chills are experienced by the mother in this stage is what is the most common complaint or observation what you make in the fourth stage. But why it is important, the fourth stage, is that you need to monitor the patient for any excessive bleeding or postpartum hemorrhage. So it's very, very crucial, and the patient has a high risk of developing an atonic PPH or even a traumatic PPH, which is unobserved or not noticed at the time of the delivery, is when you miss it up sometimes. So you have to observe the patient for the next 1 hour. In this stage, you monitor the patient with the vitals, mainly the pulse, BP, and the saturation are all checked continuously, and you also look for the palpation by the in the abdomen to see that the uterus is well contracted and retracted, and also check for the PV bleeding. So if at all there are any clots, or if there is an excessive bleeding, is what you will be alarmed to look at. So these are different stages of the labor. As I repeat, first stage is from onset of true labor pains to the end of the full dilatation of the cervix. Second stage is from full dilatation of the cervix to the delivery of the fetus. Third stage is after the delivery of the fetus, the delivery of the placenta and the membranes. And fourth stage is after the delivery of the placenta and membranes, 1 hour post the delivery of the placenta. So these are the different stages of the labor. Is it clear to all of you? Yes, students?
Yes, ma'am.
Fine. So next one is that the uterine contractions. Now, what you have to understand is there is something called as Braxton Hicks contractions. Now, what are this is throughout the pregnancy, actually, the patient will have Braxton Hicks contractions, but she starts experiencing this maybe about, in the later months of pregnancy, that is 4th, 5th month. But the frequency and the intensity of these Braxton Hicks contractions go on increasing as the pregnancy the duration of the pregnancy moves in. So throughout pregnancy, a pregnant female experiences contractions which are painless and irregular. These are called as Braxton Hicks contractions. So these Braxton Hicks contractions only become painful and they become regular and increase in the intensity, duration, and the frequency as we discussed, and they turn up into the true labor pains during contractions or during labor. So during labor, the contractions are painful and lead to dilatation of the cervix. The pacemaker of the uterine contractions is situated at the cornu. The right pacemaker predominates over the left one. Contractions spread from the pacemaker area throughout the uterus at a rate of 2 centimeters per second, depolarizing the whole organ within 15 seconds. Contractions are predominant over the fundus. That is the area where you feel for the contractions, and you monitor the contractions by feeling the fundus of the uterus, feeling for the contractions, looking for what is the number of contractions the patient is having in a period of 10 minutes. You look for the duration of the contraction as well as the intensity. Also can be kind of measured with experience. You will feel whether how intense is the uterine contraction. So these are the parameters you need to monitor, and these are the things about the uterine contractions. Next, when do you call it as an adequate uterine contraction in your normal labor? So whenever the patient is having at least 3 contractions in 10 minutes each, lasting for 45 seconds is what we call it as adequate uterine contractions. Right? So if there are less number of contractions, like less than 3 in 10 minutes, or if the duration is less than 45 seconds, then we don't call it as adequate uterine contractions. So other terminologies where we use is tachysystole. It is defined as more than 5 contractions in 10 minutes, averaged over 30 minutes. Term tachysystole can be applied to spontaneous or induced labor, and the term hyperstimulation has been abandoned now. What we use is only the tachysystole. 6 or more uterine contractions in 10 minutes can lead to fetal distress. So the definition for tachysystole is that more than 5 contractions in 10 minutes, but for the uterine contractions to cause fetal distress is when they have observed that if it is 6 or more uterine contractions, then it is called fetal distress. Hypotonic contractions mean when intensity is less than 25 mm of mercury or frequency is less than 2 in 10 minutes. What are the other things you have to understand is that the uterine contractions are measured in Montevideo units. Okay, the pressure inside the uterus during the contractions or even without the contractions, the pressure inside the uterine cavity is measured in terms of same, that is millimeters of mercury, whereas the units of the uterine contractions as a whole is measured in Montevideo unit. So 1 Montevideo unit will be equal to intensity of uterine contraction and the number of the contractions in 3 minutes. So this is how we calculate the the kind of the uterine contractions the patient is having. So in terms of Montevideo unit. So this is a very important name or a terminology you have to remember. It could be a lot of, there can be a lot of questions on it. So remember this point. Next, so the different phases of labor, the first, second, and third stage, as we discussed, will have different average uterine pressures. In the first stage, it is between 40 to 50 mmHg, and its maximum at second stage and third stage, that is it extends up to 100 to 120 mm Hg in both these phases. As it is, you all should know that a lot of pressure is needed to deliver the fetus, during the second stage as well as the placenta, and therefore the pressure will be very high. Now, other things what you have to remember as we discuss the different phases of labor, we now know that the labor has the first stage, second stage, third stage, and the fourth stage. Now, the first stage of the labor, that is the time when there is onset of the uterine contractions till the delivery of the, or till the full dilatation of the cervix, what we call is the first stage of labor. This first stage of labor is further divided into two phases. It is the latent phase and the active phase. So this phase is based on the rate of the cervical dilatation. So latent phase is the time when it takes from 0 or no dilatation of the cervix from the onset of the true labor pains until at least 3 to 5 centimeters dilatation of the cervix. That is called as the latent phase of the labor. So 3 to 5 centimeters dilatation is defined by the Williams textbook, whereas the high-risk pregnancy book sometimes, the high-risk pregnancy book says it has 4 centimeters. So 3 to 5 centimeters is what you can remember. Until that time, we call it as the latent phase of labor, right? And after the 5 centimeters, after this phase, when the cervix dilates more than 3 to 5 centimeters, up till 10 centimeter dilatation is called as the active phase of the labor, right? So latent phase of the labor, its duration is in nulliparous is 12 hours. That means it is a very long duration in the nullipara, about 12 hours. Average is about 8 hours, and it is 8 hours in multiparas, and average is about 5.6 hours. It is mainly concerned with the cervical effacement. There are two important things what you should understand here in the labor is the cervical effacement and the cervical dilatation, right? So cervical effacement is the process where the cervix, as you can see in this picture, the cervix will be kind of taken up, or the cervix will kind of what do you call it, will be thinned out, and it will become one with the lower uterine segment. Okay, so this is called as the effacement of the cervix. So I always ask the students to imagine it to be something like a balloon. So if you can imagine when you blow the balloon, how the lower part of the balloon stretches and it becomes one with the upper part, that is what happens with the cervix as well. So in this picture, you can understand here that effacement process, how it occurs. So initially, when the patient is in very early labor, when the cervix is not effaced, you do a PV examination and you can feel the lips of the cervix properly from the fornix. You can see the cervix is almost about 3 to 4 centimeters, or the ectocervix, what you can feel is properly felt when the cervix is not effaced. But when the cervix starts effacing, it becomes shorter and shorter, right? If you can feel earlier about 3 centimeters or 2.2 centimeters of the cervix initially, once it starts effacing, it will be like reduced to half. So the effacement is expressed in terms of percentage. Okay, so 0 is where the cervix is uneffaced or it is not effaced. You can feel both the lips of the cervix properly on a pelvic examination, and once it shortens to about 50% of what it was earlier, then we say that the cervix is 50% effaced. Okay, so you can see here it was about 2 centimeters, and here it's just about 1 centimeter length of the cervix. Then subsequently, once the cervix completely kind of merges with the lower uterine segment, and you can actually not feel any cervical lips when you do a pelvic examination, that is when you say that the cervix is 100% effaced and it is completely merging with the lower uterine segment. You can't feel the cervix at all. The cervix becomes short and becomes completely thin. It is like a very thin rim of tissue what you can feel. So that is when we call it as a 100% effaced cervix. Okay, so remember two things here. The cervix effacement is thinning and shortening of the cervix, and dilatation is when the canal opens up, right? So you can see here it is 100% effaced. The dilatation is just 2 to 3 centimeters, and once the cervix gets effaced, then the proper dilatation starts occurring. So from 2 to 3 centimeters, it dilates up till 10 centimeters so that the fetus completely comes out. So there are two concepts what you have to understand here. So is it clear to all of you students here? Did you understand the concept of effacement? Yes or no? Yes, students? Shirisha was there. I hope I am not disconnected with you all. Right. So did you all understand the concept of effacement?
Yes, ma'am. Understood, ma'am.
Yeah. So remember the latent phase. Okay. The latent phase of the labor is more, concerned with the effacement of the cervix. So it's quite a long time. And that is the time when we look and wait for the effacement of the cervix. So once the effacement is completed, then starts the active phase of the first stage of the labor. That is the more concerned with the actual dilatation of the cervix, right? So the active phase begins with the cervical dilatation of 3 to 5 centimeters with the regular uterine contractions and normal minimum cervical dilatation rate of 1.2 centimeter per hour for nulliparous and 1.5 centimeter per hour for the parous women. So this is the normal rate of dilatation of the cervix in an active phase of normal labor. 1.2 centimeter per hour in nulliparous and 1.5 centimeter per hour for the parous women. So the minimum dilatation should be 1 centimeter per hour. If it is lesser than that, then we say that the labor is not progressing normally. Mainly, it is concerned with the cervical dilatation. So remember, the active phase is mainly concerned with the cervical dilatation. So as I told, you must be able to differentiate between the effacement and dilatation. Here in this picture again, I would like to make it clear to you all that, here you can see the cervix. This is not effaced and not dilated. Once the labor begins, it gets effaced first. As I told, in the latent phase of the first stage of labor, it gets effaced, where the whole of the cervix is shortened, thinned out, and it merges with the lower uterine segment, and that is what you call it as 100% or the fully effaced cervix. So once it starts once it is fully effaced, you can see it's just 1 centimeter dilated here, and then begins the active phase of the labor with proper contractions. What happens is the cervix starts dilating, and it is important that it dilates at a certain rate, as that is 1.2 centimeter per hour in nulliparous and 1.5 centimeter per hour in the multiparous women. So once it is completely or fully dilated at 10 centimeters is when the patient completes her first stage of labor. Okay. Is it clear to all of you?
Yes, ma'am.
Fine. So this curve, the particular curve what we were discussing, is called as the Friedman curve. So this curve plots the dilatation of the cervix against the time, right? So this is the cervical dilatation centimeters. This is on the y-axis, and the time in hours is plotted on the x-axis. So as you can see, from 0 hours to 2 hours, 4 hours, 6 hours, the cervical dilatation is plotted. So at 0 hours, when the patient comes to you, say it is morning 7 o'clock, she comes, that is considered as a 0 hours. And when you do a PV examination, she's just 2 centimeters is when you plot it. So the normal progress of the labor, as we discussed, the normal cervical dilatation, how it should be is that in the latent phase, there is not much of a dilatation. She has just dilated from, less than 2 centimeters, just 4 centimeters. So just 1 or 2 centimeters dilated in a period of almost 8 hours, remember. So the latent phase can be up till 12 hours also in primary, as we discussed, and there is not much of dilatation of the cervix occurring during this phase. But once the patient is fully effaced and she goes into active phase of labor with good uterine contractions, then is the time that her cervical dilatation should accelerate. So here you can see the curve just accelerates, and it is steeper, as you can see. In the first phase, it is called accelerating phase. Then it is the phase of maximum slope, where she is like, if you can imagine, she's just 3 centimeters or 4 between 3 and 4 centimeters at 8 hours. And the next 2 hours, she is almost 5 centimeters. And the next 2 hours, that is 10 to 12, the next 2 hours, there is a steep rise in the dilatation of the cervix. From 5 centimeters, she directly goes to 9 centimeters. So from 9 to 10, to attain 9 to 10 centimeters is again, there is a slow in the dilatation process. That is called as a deceleration phase. So remember, this is a complete Friedman curve, which is a normal curve of the cervical dilatation of the labor. So this latent phase, hardly any cervical dilatation, just 1 or 2 centimeters dilatation will be there. But once she's in active phase, she has to go through a proper curve for dilatation. So this is what we call it as a Friedman curve. So as I've explained all this, the acceleration phase is 3 to 4 centimeters of the cervical dilatation. Phase of maximum slope is between 4 to 9 centimeters, and deceleration is phase is between 9 to 10 centimeters. So this is the Friedman curve. Have you understood, all of you? Yes, students? Any doubt in this?
No.
Fine, let's proceed. Abnormalities of the latent phase. So when you have understood what is normal, now you should be able to identify what is an abnormal in any phases of the labor, right? So when abnormalities in the latent phase could be a prolonged latent phase. So as it is, we know that the latent phase is about 12 hours in primigravida and about 8 hours in multigravida. So if the latent phase is said to be prolonged, the definition is if it is greater than 20 hours in nullipara and it is greater than 14 hours in multipara. Some of the causes for prolonged latent phase include excessive sedation of the patient, or even in epidural analgesia, there is a prolonged latent phase. Poor cervical conditions, example, thick, uneffaced or undilated cervix, or false labor pain is the most common cause in case of multipara, where you feel that the patient is in labor, but she's actually not, and you think that there is a prolonged latent phase. So that's very important to diagnose whether she's in false labor pain or she's in actual labor, right? So these are the abnormalities in the latent phase. There is a prolonged latent phase. Next is diagnosis. So the diagnosis of prolonged labor is made by observation of the Friedman curves, what we discussed. Either of the two options are used for managing a prolonged latent phase. So one is either a therapeutic rest is given to the patient, where we give her morphine, that is nothing but sedation, and then we observe the patient. If within an hour and the patient is awake 4 to 5 hours later in active labor, or if she doesn't go into labor at all. That is how we kind of manage by the therapeutic option. Whereas nowadays we don't want to wait. Sometimes the patient is already prepared for delivery and they're in the hospital. So in that case, what we do is we go ahead with induction of labor, or we kind of accelerate the latent phase by oxytocin stimulation, or we use any other oxytocic agent like a prostaglandin. We use the prostaglandin gel, or even the PGE1 gel, or the PGE2 gel, or the PGE1 misoprostol also can be used to augment or stimulate the first prolonged latent phase of the labor. So these are the options for management. Next, now what are the abnormalities of the active phase? Active phase, as we have discussed earlier, begins with the cervix is about 3 to 5 centimeters dilated up till full dilatation of the cervix, that is about 10 centimeters. So minimum rate of cervical dilatation in active phase is 1.2 centimeter per hour in nullipara females and 1.5 centimeters in multipara, as we discussed. Protracted active phase, that is very slow rate of cervical dilatation, or it is also a slow descent of the fetal head, is also considered to be a protracted or a prolonged active phase. So the features here, as we discussed, is if the cervical dilatation is less than 1.2 centimeter per hour in nullipara, or less than 1.5 centimeter per hour in multiparas, when we consider it as a prolonged active phase. Whenever there is a less than 1 centimeter descent of the fetal head, or less than 2 centimeter per hour descent of the fetal head in multiparas, that is also considered to be a protracted active phase. So the descent of the fetal head is again an important parameter what we assess in the monitoring of the labor. So I'll just explain to you in subsequent slides. So what do you do when there is a protracted active phase? You do an expectant and a supportive management can be done if the CPD is ruled out, that is, there is no cephalopelvic disproportion. In that case, you can augment the active phase of the labor by giving her oxytocic drugs, by supporting her and seeing that she gets adequate uterine contractions so that the cervix gets dilated at a proper rate and the head descends well. So this is the expectant and the supportive management what you can do. But if there is a cephalopelvic disproportion and you see that the labor is protracted or the active phase is protracted because of the CPD, where there is no possibility of the labor progressing normally and the baby getting delivered normally, then you go ahead with the cesarean section. So that's how the options of the management for the protracted active phases. So arrest of dilatation is when cessation of the dilatation for 2 or more hours is called as arrest of dilatation. Arrest of descent is called when there is a cessation of the descent for 1 or more hours. Okay, so these are arrest of the labor, arrest of the dilatation or arrest of the descent. So these are the definitions for the arrest of labor. Protracted or prolonged labor or the active phase is different. Arrest is different. So that is how you should understand. So slow dilatation of the cervix or slow descent of the slow rate of descent of the fetal head is called protracted or prolonged active phase. Whereas if there is arrest or no dilatation for more than 2 hours or no descent of the fetal head for more than 1 hour is called as arrest of dilatation and arrest of descent. So this is how you should be able to differentiate and remember these different situations. Okay. So another important thing what you have to remember is the ACOG is the American College of Obstetrics and Gynecologists have suggested that before the diagnosis of the first stage of the labor is made, the following criteria should be met. What are they? First is the latent phase has been completed and the cervix is at least 4 centimeters or more dilated. Also, uterine contraction pattern of 200 Montevideo units or more in a 10-minute period has been present for 2 hours without the cervical changes. Now, this 2 hour study is being challenged and the Williams textbook says that it should be at least 4 hours. But then according to the WHO or even the routine practice, we considered it as 2 hours and not really wait up till 4 hours theoretically, right? So these are the two important criteria to say that there has been a delayed or a protracted active phase or latent phase of the, protracted active phase of the labor, right? So these are the two important criteria to remember. Next, factors contributing to the arrest or dilatation are excessive sedation of the patient, epidural analgesia, fetal malposition, CPD. And recommended therapy for protracted disorders is expectant management, and for arrest is in oxytocin absence of any cephalopelvic disproportion as we discussed earlier. Okay. Is it clear to you all? The abnormality in case of active phase of labor?
Yes, ma'am.
Okay, so considering that, we'll move on, come to the second stage of labor. Now, as we discussed, second stage of labor is from the full dilatation of the cervix, that is 10 centimeter dilatation of the cervix, to the delivery of the fetus completely. Now, that is the second stage of labor, right? So in the second stage, the expulsive efforts by a woman play more important role than the uterine contractions. So this is very, very important phase for the mother. She has to be fully alert and awake to give a proper effort for the delivery of the fetus, and that's very, very important to see that the baby delivers well and without any distress and delay. Okay, so these are the different pictures what you can see in the second stage of labor, where there is extension and delivery of the head occurs first, and then after the delivery of the head there is an internal rotation of the shoulders. The anterior and the posterior shoulder come lying in the anterior posterior diameter of the pelvis. The posterior shoulder is delivered first, and then delivered the anterior shoulder, and then the whole of the trunk and the fetal legs you easily come out. So this is how the delivery of the normal baby occurs. Next, the duration of the second stage of labor is also very, very important. And in nulliparous, it's about 1 hour, and multiparous, it's about 30 minutes. But it can be considered normal whenever you're given an epidural. It's 3 hours and 2 hours, right? So, it's about 1+ hours for the normal epidural, whereas if it is more than 3 hours, it is called as prolonged even with epidural, and more than 2 hours is in multiparous with epidural. Whereas without the epidural, if the second stage of the labor prolongs for 2 hours or more in nulliparous and 1 hour or more in multiparous, it is considered as prolonged second stage of labor. Okay, so when there is no change in the descent of the head for 1 hour or more than 1 hour, it is called as prolonged second stage of labor. So this is an important chart what you have to remember. Normal duration, prolonged without epidural, prolonged with epidural. Nulliparous, multiparous, 1 hour, 30 minutes, 2 hours, 1 hour, 3 hours, 2 hours. Okay, it's a very important slide to remember. Next, third stage of the labor. So third stage of labor extends from the birth of the child to complete expulsion of the placenta and membranes and contraction and retraction of the uterus. So the third stage can be managed by expectant management or active management. Expectant management, what we do in this method is that the placental separation and its descent into the vagina is allowed to occur spontaneously without any assistance or with minimal assistance of kind of helping it to be delivered. That is expectant management. The duration of third stage is 15 minutes when there is an expectant management. So there is increased chances of bleeding, increased chances of PPH, and increased maternal mortality if what they've observed in case of an expectant management. So that's why the routine recommendation for the management of the third stage of labor is now the active management of third stage. So what do you mean by active management of third stage? In this method, the placenta separation is actively facilitated and powerful uterine contractions are initiated to reduce the incidence of third stage of complications like PPH. So what you do here is like there is an uterotonic which is administered soon after the birth of the baby. Uterotonic means the injections of oxytocin, or we give you prostaglandins like prostadine or even the misoprostol. Any one of the uterotonic is administered immediately after the delivery to induce strong uterine contractions. So that helps in separation of the placenta as well as its expulsion. So what happens in this case is that the duration of the third stage is reduced to almost 5 minutes from 15 minutes, and therefore there is less chances of bleeding, less chances of PPH, and less maternal mortality has been observed whenever they have compared huge studies with expectant and active management. So right now we do the active management of labor, where always we use an uterotonic just at the delivery of the baby. So what are the steps of active management of labor? As I told, a uterotonic is administered soon after the delivery of the baby. Then the cord is delayed, the clamping of the cord is delayed. You don't clamp it immediately. You allow the blood to pump into the baby for some more time, and once the pulsation stops is the time when you clamp with the cord and cut it. And the delivery of the placenta is done by controlled contraction rather than allowing it to be delivered on its own. We do a controlled contraction, which is the procedure used, and the cord is pulled in a downward and forward direction, and with the right hand, and the left hand will put a pressure on the fundus of the uterus, and the pressure is put in the opposite direction, that is backwards and upwards. So that is the traction and countertraction method, and then you deliver the placenta, followed by uterine massaging is done to help it contract and retract more thoroughly. So these are the steps of the active management of labor. Remember, administration of uterotonic, delayed cord clamping, delivery of the placenta by controlled contraction, and uterine massage. So these are the steps of the active management of third stage of labor. Is it clear to all of you?
Yes, ma'am.
Right. So then only thing what you have to remember is that the only drawback of active management of third stage of labor is that since the uterotonic agent is given at the delivery of the shoulder before the delivery of the placenta, it can lead to increased chances of retained placenta. But if you give it a little later, that is after the delivery of the fetus, and not giving at the delivery of the shoulder, there are lesser chances. So this one is the drawback you can remember. Now, Other points what you have to remember is normally in active management, as we told, we do the delayed cord clamping, but in certain conditions we have to do an early cord clamping. That is, immediately we have to clamp the cord. So which are these conditions? Is one is in preterm labor or a growth restricted fetus due to risk of hypovolemia. Even an extra 40 to 50 ml blood can cause congenital the congestive heart failure in premature infants. Thus the cord is clamped immediately. Birth asphyxia, first immediately resuscitate the baby and think about anything else. So that's why when you have a birth asphyxiated baby, immediately you have to clamp it and hand it over to the pediatrician for resuscitation. Then in case of RS isoimmunization, when the patient is RH negative and you don't know yet the baby's blood group, so you have to clamp the cord immediately in HIV positive females as well as maternal diabetes. So these are the conditions where you need to take extra precautions and see that you clamp the cord immediately, right? In contrast to the normal active management of labor. Okay. Next. So that is about the third stage, or the active management of the third stage. Another thing what you have to remember is when do you know that the placenta has separated and how do you deliver it? So what are the signs of placental separation? It's very, very important to identify these signs so that you do not mismanage the third stage of labor, which is very, very critical. So mismanagement of the third stage of labor also leads to PPH and even other complications, like even sometimes uterine rupture or uterine inversion, where inadvertently before the placenta gets separated, you try to give a traction on the placenta, pull it up, and the uterus is not contracted and atonic uterus. It leads to complications, as I discussed, like uterine inversion. So it's very important to identify that the placenta is completely separated, and then only you attempt to deliver the placenta by traction or the controlled contraction method. So what are those signs of placental separation? You have to observe per abdomen and per vaginal. Per abdomen is where the uterus becomes globular, becomes round, it becomes firm, and it becomes ballotable. Ballotable means it is easily kind of movable in between your fingers, right? So it becomes quite hard and firm. So that is the earliest sign to appear on the abdomen. Then the fundal height is slightly raised as the separated placenta comes down in lower uterine segment and uterus rests over it. This is called as the Schroeder's sign. Okay, then slight suprapubic bulging may be seen due to separated placenta distending the lower uterine segment. On pushing the uterus cephalad means upwards with the hand on the abdomen, the cord no longer recedes. This is Kussner's sign. So normally what happens if the placenta is not yet separated, when you push the uterus upwards, so the fundus upwards, the placenta or the uterus will pull up the cord as well, right? So you will see that the cord also goes up when it is still not separated. But if it is separated, then it will come and lie in such a position that even though you push the uterus upwards, it's not going to recede up back, and there is no movement of the cord seen on the at the perineum. So this is called as Kussner's sign. So these are the signs what you observe on abdomen. Whereas per vaginally, what you'll be able to see is there is a sudden gush of blood, fresh blood coming out, and there is permanent lengthening of the cord. So you can see that the cord is actually kind of descending down. So how we usually identify this procedure during the normal delivery is we clamp the cord very close to the vaginal introitus, and we keep that position, or we keep that the cord clamp at that position at the vaginal introitus. And whenever there is a separation of the placenta and whenever there is a lengthening of the cord, you can actually see that the clamp is moving along with the cord downwards. So that's how you identify the actual lengthening of the cord and identify the placental separation, and then you attempt to deliver it properly. So this is very important to identify, to understand, and especially in the practice of a normal delivery. Is it clear to all of you? Anybody has attempted a delivery? Anybody has conducted a delivery and helped out with the delivery of the placenta? Any one of you?
Yes, ma'am.
So have you been able to identify these signs when you're trying to deliver?
Yes, ma'am. We did the control contraction.
Okay, so you could do the controlled contraction delivery of the placenta. Could
Yes.
you identify the signs of vaginal, placental separation? What we discussed? Any one of the sign
Yes.
you could identify?
Yes, ma'am. This globular and forum palatable and this lengthening of the and sudden gush of blood is also seen.
Okay, right. So that's very good that you are able to appreciate, and you should be able to remember these things, so that you don't forget those things. So it's very important to remember these things. And of course, they're important to theoretical as well. Remember these Schroeder sign and Kussner's sign. Okay, so good. So when we move next, once you have understood the different stages of labor, then the next important thing to understand is the mechanism of labor. So what do you mean by mechanism of labor? It is the manner in which the fetus adjusts itself to pass through the parturient canal with a minimum difficulty is what is called as mechanism of labor. So it's the maneuverability or the cardinal movements which are occurring in the body of the fetus while negotiating the pelvic cavity, and the delivering process is called as the mechanism of labor. So there are 8 important cardinal movements composing the mechanism of labor during the normal labor, what we're discussing now. So these usually occur in stepwise manner. So they're the first thing and the last thing to occur. So remember, you have to remember in this same series of events, right? So first one to occur is the engagement. Second is the descent. And remember here, the descent occurs throughout the process of the second stage of labor, right from starting to the end, okay? So this is one procedure which is occurring throughout. And it's not at one time during the second stage. First is the engagement. Descent, flexion is where the head of the baby is more flexed so that the chin touches the chest of the baby. That is called as the flexion, the moment of the flexion. Then there is something called internal rotation. So as you can see here in this picture, the head is still floating in the first one. In the second one, it is engaged, where the biparietal diameter of the fetus is crossing the pelvic brim. That is when we call it as the engagement. We'll discuss more about the engagement in subsequent slides. So this is the engagement occurring, and as well as flexion is occurring, where the fetal chin almost touches the chest and it becomes more flexed, it becomes more curled up. That is called as a flexion, and at the same time there is descent occurring. So another important terminology, the internal rotation, what you have to remember is the rotation is measured by the help of locating the the occiput of the baby, right? So if you consider the pelvic cavity, when you're doing a pelvic examination, this is the pubis and this is the coccyx. So you look or you try to feel for this sagittal suture, right? So you will be able to feel the sagittal suture, and you will be able to feel the anterior frontanelle and the posterior frontanelle, right? So when the baby is well flexed head, what happens is when the chin touches the chest of the baby, so you should be able to directly feel this portion of the fetal head. That is, you'll be able to feel the occiput properly, and with very little difficulty you will be able to feel the anterior frontanelle, which is more inside. So that is how it shows that the baby is in a well flexed position, right? That is how you assess whether the degree of flexion is adequate or no. So you will be able to feel the posterior frontanelle easily when you do a pelvic examination, and with the difficulty you should be able to feel the anterior frontanelle, which is more towards the pelvic cavity. So this is the flexion. Then about the rotation, as I was discussing, the sagittal suture, the direction of the sagittal suture will tell you I'll just use the pen here. The direction of the sagittal suture will tell you the internal rotation. So always you have to imagine a transverse line on the pelvis here, and try to feel the sagittal suture with respect to this transverse line. So when you see the sagittal suture is in this position, and you can feel the posterior frontanelle here and the anterior frontanelle here, it means that the baby what the posterior or the occiput is in the, if you can imagine the quadrants of the pelvis, this is the mother's right side. Okay, this is the mother's left side, correct? So when you're doing a pelvic examination, so wherever you're able to feel the occiput of the baby, that is the occipital region in the vertex presentation, is what you have to note. So if it is in this position where you're feeling the occiput in the left, upper anterior quadrant of the mother's pelvis. So this is right, this is left, as I told, this is anterior, and this is posterior. So when the occiput is lying in the anterior part of the pelvis on the left side of the mother, then we call it as what position it is called? Anybody? And that is the most common position the baby will be presenting, that is LOA, correct? So left occipito anterior, right? So in this stage of the labor, you will be able to assess that the baby or the fetus is lying in a left occipito anterior position. So as the labor progresses, and when you do PV examination after 2 hours or 4 hours, how do you assess the internal rotation is that you will observe the position of the occiput again, right? So with respect to the maternal pelvis, if the occiput or the position of the fetus was LOA, if there is an adequate rotation, especially at the end of the second stage of labor, what should happen is the sagittal suture should come in line with the anterior posterior line of the pelvis. The occiput should be lying here and the anterior frontanellae almost direct posterior. So this is the time when you can assess that the internal rotation is complete and the occiput is lying just below the pelvis. So from LOA, it will become direct occipito anterior. Understood, all of you? You can see here in this picture, the occiput is lying just below the pelvis, and this shows that the baby has rotated from LOA to complete occipito anterior position. That is, the complete internal rotation has occurred. Did you understand, all of you? Yes or no?
Yes, ma'am.
So that is about internal rotation. So once the internal rotation is completed and the occiput is lying below the pelvis, then the next step of delivery is the crowning. So crowning is a stage where the fetal head will occupy or will stretch up the introitus of the mother to such an extent that in spite of the contraction going away, it will stay in that position and the fetal head will not recede back. So that step is called as a crowning. So after the crowning, the next step is extension, and with the help, when the extension occurs, so remember always the baby is in a flexive position until it is almost crowning, right? So and internal rotation has completed. Once the internal rotation is completed, the baby is almost on the pelvic floor, crowning occurs, and there occurs the extension. That means the baby's chin will start moving away from its chest and it will get extended. The neck gets extended. So with the help of this movement, that is extension, what happens is the head gets delivered. So once there is an extension movement, remember the first part of the baby to deliver is the sinciput or the fetal head. Then comes the forehead, and then the face, the chin is the last thing to deliver. So it occurs in this direction. So this is how the extension occurs and the baby's whole head is delivered. So that is extension. After extension is some very subtle movement called as restitution, which occurs because of the restoration of the neck rotation. So that occurs, that is called as restitution. It's very hard to observe or kind of appreciate restitution. It comes only with, after a few more deliveries you will be able to appreciate this movement of restitution, but it's just the untwisting of the neck which has occurred during internal rotation, right? So that is called as restitution. So that occurs after the delivery of the fetal head. So once there is restitution, what happens is once the fetal head is delivered, there is internal rotation of the shoulders occurring actually. So the internal rotation of the shoulders occur. So initially the shoulders are in transverse position. Then once the internal rotation of the shoulders occurs, the anterior shoulder, the right shoulder, in case of LOA, right shoulder of the baby will come to lie under the pubis, and the left shoulder at the posterior aspect. So then what happens is, because of with the turning or the twisting movements of the fetal trunk, the posterior shoulder is usually delivered first, and then the anterior shoulder is delivered when the baby is head is pulled down, the anterior shoulder is delivered. So the rest of the trunk and the legs come out easily. So this is how the cardinal movements of the delivery or the mechanism of labor occur, and that's the process wherein each part of the baby is delivered. You all understood this? Any doubts in the mechanism of labor? Yes, students?
No, ma'am. No, ma'am. Understood, ma'am.
Okay, so this is very important to understand, because only when you understand what is normal will you be able to understand what is abnormal. Like, for example, deflexed head. What do you mean by malrotation? What do you mean by arrest of rotation? What do you mean by descent? Abnormal descent. So all this you will be able to understand only if you understand the mechanism of labor, and you should be able to understand the different positions very well. That is left occipito anterior, left occipito posterior, transverse, and then you will be able to understand the abnormal positions like direct occipito-posterior, or the right occipito-posterior, or the left occipito-posterior. These are abnormal positions, or they take a long time to deliver, and sometimes they turn into different kinds of deliveries. What we can think of is, one is in the cephalic presentation, what we discuss now is the normal mechanism of labor, whereas sometimes if there is an occipito-posterior position, what happens is the occiput will come and lie, it occurs in the reverse order, like the occiput will come and lie here in the posterior part of the pelvis, and the anterior frontanale will be above the pubis, and then the face, there is a delivery occurring of the baby. So what kind of delivery is that called when there is a direct occipito-posterior? Anybody can tell me? What kind of mechanism of labor occurs and what kind of delivery is that called?
Face to pubis delivery.
Face to pubis, very good. So it's called, it occurs in a face to pubis delivery manner. That means the face is towards the pubis. Okay, normally in the occipito anterior, what happens is the head is towards the pubis, whereas in case the occiput is posteriorly here, the face will be towards the pubis, right? So you can see here the opposite occurring, the face will be towards the pubis. So that's how the delivery will be there, where the head and the other parts are delivered by flexion, and then the face is delivered by extension. So that is again in an abnormal labor. I'm not going to discuss much here, but you remember that is called as face to pubis delivery. Okay. So since it's clear to all of you the mechanism of labor, we'll move ahead. Now, as we discussed the different steps in the mechanism of labor, it's important to understand one very important step, that is the first step, that is engagement. So engagement is said to occur when the greatest transverse diameter of the presenting part, that is the biparietal diameter in case of vertex presentations, will pass through the pelvic inlet. Okay, in all the cephalic presentations. So the greatest diameter is, or transverse diameter is, always the biparietal diameter. So remember the simple ways you remember that whenever there is a cephalic presentation, the biparietal diameter is the largest transverse diameter of the fetal head, and if that passes the pelvic inlet or the pelvic brim, then we call it as engagement of the fetal head has occurred, right? So this is what you have to understand. by what do you mean by engagement? Now, engagement occurs in multipara with commencement of the labor in the late first stage after the rupture of the membranes, whereas in nullipara it occurs even before the onset of the labor, especially after at about 38 weeks of gestation. So it occurs earlier in nullipara, and it occurs almost in labor or late first stage in multipara. This is what is engagement. Okay. Next, in primaries, the most common cause of non-engagement of the head is usually the deflexed head or occipital posterior position, followed by cephalopelvic disproportion. And the engagement of the head rules out CPD at the level of the pelvic inlet. Remember always that whenever you feel that the engagement has occurred, it means that there is no CPD at the pelvic inlet. Then if the head is engaged, it means that it has to be at zero station. Now, this is another concept. What you have to understand is always the descent of the fetal head is measured in terms of a certain level of standard, that is at the level of the ischial spines. So the ischial spines, or the plane of the ischial spines, is considered to be a zero station, and anything above that is called as minus 1, 2, 3, and 4, and anything below that is considered plus 1, 2, and 3. Right? So whenever there is an engagement occurring, that means when the biparietal diameter of the fetal head crosses the pelvic inlet, the plane of the pelvic inlet, the lowest portion of the fetal head should lie at the level of the zero station, that is at the level of the ischial spines. Right? So that is what you have to kind of confirm, or both should correspond. So when we do a per-abdominal examination, you should be able to feel that the head is engaged. And when you do a pelvic examination, you have to feel the lowest portion of the fetal head at the level of the zero station. So only then it means that the fetal head is engaged, or the biparietal diameter has crossed the pelvic inlet. Is it clear to all of you?
Yes, ma'am.
Yeah, so this is how we also measure the rate of the descent of the fetal head during the normal delivery. So in the abdominal palpation, when you try to feel the head of the fetus, you will measure in terms of the width of the fingers. So what you call as the fifth rule, right? So whenever the head is not engaged, or it is floating, you will be able to feel 4 fingers width of the fetal head above the pelvis, above the pelvic brim on the abdomen. So you call it as 4/5 palpation. So when the engagement occurs, what happens is like almost half of the fetal head goes down. So ideally, when there is engagement occurring per abdomen, you should be able to feel only 2/5 width of the finger of the fetal head should be felt per abdomen. And when you do a PV, it should be lying at a zero station. So that is how you can assess the descent of the fetal head during the labor. So from 4/5, it should descend to 3/5 to 2/5. And that is when the engagement has occurred. Then it has to come down to 1/5 and 0, or when it is not palpable per abdomen, it means that it is almost at +3 station. Correct? So it has to correspond with your abdominal examination as well as the pelvic examination. So this is how you should be able to assess the descent of the fetal head, and also understand what you mean by engagement, where the fetal head has to at least come and be at the level of the zero station, that is at the level of the ischial spines. Is it clear to all of you? Yes? Yes or no, students?
Yes, ma'am.
So there's no doubt in understanding of the engagement and the station of the fetal head?
No, ma'am.
Okay. So another thing now, the next thing what you have to understand is there is abnormalities in the engagement of the fetal head. So normal engagement of the fetal head occurs with synclitism. So synclitism, and if there is an abnormal engagement, it is called as asynclitism. See, what happens in the normal engagement is that you can imagine this picture is not very clear, but imagine that this is the pelvic cavity when you're doing a pelvic examination, and when the head engages, the sagittal suture should be corresponding to the transverse plane of the maternal pelvis. Okay, so when this occurs, and when the engagement occurs in this plane, and where the anterior sagittal suture is corresponding to the transverse plane of the maternal pelvis, this particular thing or engagement is called a synclitic engagement of the fetus. That means the engagement is occur in a synclitism. If there is a deviation from this, where the fetal head will engage in asynclitism, then we call it as asynclitism. So asynclitism can be two types. One is anterior parietal bone presentation or posterior parietal bone presentation. So what happens in anterior parietal bone presentation is that in the anterior parietal bone presentation, what happens is this suture, the sagittal suture will move towards the posterior aspect of the mother. It will turn towards the posterior aspect of the mother, and what you can feel on pelvic examination is the anterior parietal bone of the fetus, right? So that kind of asynclitism is called as anterior parietal bone presentation or anterior asynclitism. When there is the tilt of the baby, or the baby's head is in the opposite direction, where the sagittal suture moves towards the anterior part of the maternal pelvis, that is towards the pubis. So what you can feel on pelvic examination, the first thing is the posterior parietal bone is more obviously felt. So this kind of engagement or asynclitic engagement is called posterior parietal or posterior asynclitism, posterior parietal bone presentation. Okay, so this is a very interesting photo I found on the net, and I just put it up here. Somebody has really drawn it very well to make you understand, in this plane, in the sagittal plane. So this is like posterior asynclitism, where the sagittal suture is towards the pubis, and what you can feel on pelvic examination is the posterior parietal bone of the fetus. When it is anterior asynclitism, what happens is the suture is towards the maternal pelvis, towards the sacrum, and what you can feel on pelvic examination is the anterior parietal bone of the baby, right? So this is anterior asynclitism. Is it clear to all of you?
Yes,
Normally what happens, it should be this. The sagittal suture should be in line with the transverse diameter. Okay, this is normal. So now you should be able to understand what is anterior parietal bone presentation or anterior asynclitism, and posterior parietal bone presentation or posterior asynclitism. Is it clear to all of you?
Yes, ma'am. Clear, ma'am.
Yeah, next. So as I told, when sagittal suture of the head of the fetus lies in transverse diameter of the pelvic inlet, midway between the pubic symphysis and the sacral promontory, it occurs in 25% of the cases. This is called synclitic engagement. Asynclitic or anterior engagement, sagittal suture is defected towards the sacral promontory. It's also known as anterior parietal presentation, or it's also called as negligence obliquity. It occurs commonly in multipara. Sagittal suture in asynclitic posterior presentations is defected towards the pubic symphysis. The posterior parietal bone thus becomes the leading part, and it's also called as Litzman obliquity or posterior parietal presentation, and occurs more commonly in nulliparous women. So these are the important features you have to remember between asynclitic anterior and posterior. Okay. Next one. So what are the causes of non-engagement of the head in the nulliparous? A term we did discuss a few points earlier. Also, you remember any malpresentations, occipito-posterior position, deflexed head, CPD or cephalopelvic disproportion, placenta previa, tumors in the lower segment, tumors of the fetal head, neck or cord around the neck, hydrocephalus, polyhydramnios, and distended bladder or rectum also sometimes prevents engagement. So these are the common causes of non-engagement of head in the nullipara at term. So this is again the same thing. I want you all to be thorough with the understanding of what you mean by engagement, what do you mean by descent, and when you call it as an engaged and non-engaged head. Is it clear to all of you?
Yes, ma'am.
Fine. So yeah, I think I'll just cover it up till CPD for today's class, and regarding the partogram and other aspects of labor we'll discuss in the next classes. So what do you mean by CPD? Cephalopelvic disproportion. It can occur at any stage of the labor. It can occur at any level of the pelvis. So it could be at the inlet, inlet, mid cavity, and the outlet. Okay, so engagement in vertex shows that the BPD has passed through the pelvic inlet and the lowermost part of the head is at the level of the ischial spines. That is what you need to understand. And whenever there is an engagement occurring, that means the BPD has crossed the pelvic inlet. It shows that there is no CPD at the inlet, right? So that is one indication. Whenever there is an engagement, there is no CPD at the inlet occurring. So that's an important sign. And the other way around is also true. That means that if there is no engagement occurring, we have to suspect that there could be a CPD at the level of the pelvic inlet itself, right? So this is how you have to understand. Next, CPD can be true or relative. True CPD is relatively rare and occurs when the presenting part of the fetus is too big or the pelvis is too small, as in pelvic dystocia. Now, pelvis dystocia is uncommon in developed countries but may occur after trauma. In developing countries, it is seen in vitamin D deficiency and rickets. Relative CPD is the most common and it is associated with the fetal malpositions such as occipital posterior positions or a bro presentation. So this is about CPD. So students, I think I'll stop the class here and I'll continue with the rest of the things in the next class because it will require a more elaborate explanation. It's very important for you all to understand the other features like the partogram and etc. So until now, I hope you have all understood the important aspects of the labor. As I have discussed, one is the definition of the labor, then that is a normal labor. Then what do you mean by eutosia? What is the term called dystocia? What is pre-labor, false and true labor pains? Then you should definitely understand the stages of the labor. How do you identify the uterine contractions? What are the normal contractions? What are the abnormal contractions? Then, of course, the different stages of the labor you should understand, and what are the normal, events in different stages of labor. What is the normal duration is what you need to understand. What is cervical effacement, cervical dilatation? Then the different phases of labor, that is first phase, second phase, third phase. What are the abnormalities of each phase? And how do you manage is what is important to understand. And of course, the mechanism of labor, normal labor, and what do you mean by asynclitism, and engagement we have understood, and CPD. Okay, so is it all clear to all of you until these points? I hope you all have understood well.
Yes, ma'am.
Okay, anybody has any doubt or any question? Yes, students?
No doubt, ma'am. No doubts, ma'am. Thank you.
Okay, so please go back and read your textbooks well so that you can understand it much better. And you can always come back to me regarding any doubt you have after you have read the topic properly. So I'll continue with the same topic in the next class, and we'll discuss about the rest of the things like I've told, partogram and the pain management and all about labor. Fine. So thank you all students for attending the class, and I wish you all a very, very happy Deepavali. Have a safe and happy time, happy family time with all your family members. So I'll see you next week then.
Thank you, ma'am. Happy Diwali.
Thank you all.
Yeah, thank you all. Thank you so much. Pulkesh?
Yes, madam.
Yeah, I think we're done with the class, so you can put it off.
Sure, madam. Sure.
Yeah, thank you. Thank you so much.